Okay. Hello, everybody. It seems my microphone is activated. Is everybody hearing me or listening me? Then I turn on my camera. Seems to be no forward today. Okay, then I will share my screen so everybody will see this. 1 second. One moment. Okay. Oh, so now you see my now you see my desktop. That's not too good. Okay, I will turn on this. Okay, does everybody see this? Yes. Okay. Okay, this time I want to give you a little insight. This time I want to give you a little insight on the practical part of the FDM. So I want to show you some techniques from last time. So do you have any questions from last time? Are there any questions? Some of you already sent me videos or called me, or I helped already some of you. Do you still have some questions from the last time? Please write it in the chat box. Everything's fine so far from the last seminar? Okay, then we will start with a practical part. Guten Abend. Okay, 1 second. I will try to share my screen a little bit better, like this. This should be better now. Okay. Okay, so I wanted to show you the HTP technique for the neck and for the hip, if that is okay. For the neck, the body language is the patient pushes with several fingers into his neck like this. Yeah. Can everybody see the presentation and the camera? Could you write me a little comment in the chat box? Yes. Okay, fine. Thank you. So the body language is like this, you know, the patient presses with several fingers in here. Sometimes they are pushing a little bit more here, but mostly they are pushing into here. So what we are doing is we are standing behind the patient and we are just pushing down. Just make sure that if you're standing behind the patient, that your arm is mostly like this. So then you have the correct vector. And then in the neck, a very important thing is that you don't press too hard on here, that you always look for the way where the tissue goes best into it. You know, if this is stuck like this in here, then always look that you look for the best way where the tissue wants to go. Because one time I pressed too hard on a patient and too long, and the patient had an accessorious paresis only for a few minutes, but this can stay for longer times. So please make sure if you treat the HTP, always move your thumb like walking down the stairs. Yeah. And don't press into the trapezius just as you see it in the picture. Please go before the trapezius. Even if the patient is showing it in the back, move the trapezius to the back and then go in there. Sometimes some patients are too nervous or too tense, or it's hard to treat it in the sitting position. Then you have to choose the laying position. Yeah, this is also okay. But mostly I do the sitting position. HTP stands for herniated trigger point, as you see right here. Yeah. So always think of the 3 factors of treatment. So positioning, direction, always move the thumb, amount of pressure. This is not so important. So I will show you 2 videos where you can see how I treat the HTP. So here I just find the spot of pain and then I move the head of my patient. Then you can take the arm as you see it in here. You can move the head, you can do whatever you want. Or you cannot move the neck, you can just pull on the arm. You see, I put the arm between my legs, I pull on the arm, and I push the tissue. I think the HDP can lay like this or like this. So if you push now on the arm, you open it. If the HDP, the opening is laying like this, if you would push on the arm, you would more close it. So then I move on the head to open it. And while I'm moving the patient's head or arm, I'm pushing inside. You could also ask your patient, if you push the right spot, then you could ask your patient, please move your head by yourself. Please get out of the pain. Is that clear? Does that make sense? Mostly I make a big thump like this and I roll over the neck, and mostly I do it like this, that I communicate with my patients, that I ask them, is this the spot? Or then they will tell you. Sometimes you have 3, maybe 2 spots in here. It feels like an almond. The old massagist, they always said, it's a myogallosis, or some say it's a trigger point. The best position is where the patient has only low pain, maybe not even pain, just discomfort while you push, and when you feel it goes good inside, when you feel really you can move the tissue. Also, yes, the patient can show you the direction if they push in here. And what I also ask my patients is that I ask them, do you have a comfortable position? Maybe some patient tell you, I cannot lay on my right side anymore because my arm falls asleep and I have this tension on my neck, so I would never treat it on the right side. Then I ask my patient, so how do you sleep now? How is it more comfortable? Then he says, maybe an example. He says like, now I'm just laying on my back, I'm putting my arms here. So then I would treat in this position. Maybe maybe a patient tells me, it's best like this, when I lift my arm up like this, and then I feel I release the tension. Then I would treat in this position. So always ask your patient, do you have a position where it feels better, and treat in this position. Because if you don't treat in this position, then the tissue will always be pinched, but this is the position of release for the patient, so they can tell you mostly very good. Sometimes the patient will be surprised that you start to ask them. They are not used to it, that the doctor or physiotherapist ask them, but you see, you will get better and better and better. And if you push into the trapezius, I feel you cannot really move the tissue. I have no success. I watched some old videos by Dr. Typaldos. I saw him pressing into the trapezius. I did it in my clinic, but actually I have more success when I move the trapezius to the back or to the side, and then I push down, and then I just move the tissue down. And of course, I don't press on the first rib. Yeah. Sometimes when I have patients who have this body language, who show it really in the back, nearly on the first rib, like this, then I do it in prone position and the patient lifts his arm. Then I can better come under the trapezius here and then push down. This works really good. So if it works for you, push into the trapezius. I'm no enemy of it, but I tried it in my clinic and it didn't work out. Yeah. So that's the SCHDP. That's the supraclavicular herniated trigger point. And this is the treatment, what you just saw in the videos. Is that clear for you? Okay, very good. What I can tell you for the clinic is I mostly see this in patients who have lack of shoulder abduction. And today I had 2 patients with this HDP who could not move their head. They move their head like this. And I mostly hear from them that when now it gets cold here in Germany, it starts to get cold. And then I see a lot of patients with SCHDPs. I see a lot of women actually, they always wear a scarf or something around here because they always feel the cold is not good. Because then they say, I have a blockation in my neck, and their body language is like this. So when the patients apply heat at home, I always tell them, yeah, apply heat, but after the heat, do a little bit of massage. This is a better treatment for HTP, because if they only treat it by heat, then it's not so good. I think it just opens a little bit, and if the heat effect is gone, then it will close again. So heat application in combination with some pushing, this is a very good treatment. The best position for me for treatment is the sitting position, because actually I'd like to be on the same level as my patient, because I think this is a physiotherapist problem. Always the physiotherapist, they let their patients lay down. I think physiotherapists, I don't know if they teach this in physiotherapy schools, but I think they think the treatment table has a special healing force. But I think when the patient is laying on the table and he looks up to you like this, then he thinks you are like a god. The patient will expect big things from you. But if you're on the same level with your patient, this is a better treatment position, I think, because we should stay on the same level, and the patient is not expecting big things. He treats you as a normal human and not like God. That's why I like the sitting position, but it's up to you what you like. And the movement of the head mostly is limited. Yes, that they have a lack of range of motion, that they cannot move. Sometimes they cannot move at all. They move like this, and then they say, it's here. I know it in the old Italian mafia movies. The guy was like this. Maybe the mafia guys all had HTPs. I don't know. But you see it like this. They have one side is okay, and the other side it's really painful. Sometimes in my clinic, I test also the side bending, and I see a lot of times that when they have trigger bands here, they have problems when they put their head to the other side. They show you like this. But when they show to the same side, then it gets pinched mostly more, and then they show you HTP. So sometimes I test the side bending too. Okay, this is a very, very good spot for treatment. I would call it a $1 million technique that Dr. Tupaldos found here. For shoulder abduction and head rotation, this is just a perfect technique. And the more HTPs you will treat, the better you will get, and the better results you will have. Yeah, just try to follow the tissue, make a retest. Sometimes you have even 2 HTPs here, so you will see maybe in the first treatment, patient shows you here. Then in the next one, the patient will maybe show you more outside. Yeah, it doesn't feel better. Yeah, the release position is the best, but we always try to have, as I explained in the last seminar, we always try to have objective findings in our patients. And I think it's best to communicate with your patient, because the patient knows. And if you ask your patient, if I turn your head here, I do it like this in my clinic. I push. Now I say, is this the spot? Patient says, oh yeah, yeah. And then I push and I push, and then I tell the patient, in this direction, I feel you resist more. It's worse. Then the patient says, maybe, yeah, yeah, yeah. And to this side, oh, this is better. Then I go to this side while I push. I ask the patient, and I communicate and synchronize with the patient. This is very important. Don't always follow your own logic. Communicate with the patient. This is very important for successful FDN treatment. And you will see the patient will be really happy that you integrate him or her into the treatment. Okay, then the next HTP, what I see a lot in my clinic, is the femoral HTP, and I also treat the bullseye. I will explain this later. I showed you a video in the last seminar from a soccer player, Agüero. He just shot a goal, and after the goal, he has pain. Okay, maybe I show it again. See, he touches his groin first with his thumb, then with his fingers, and he shakes his leg. Yeah, this is I would see this as a self-treatment already, the shaking of the leg. See, first he pushes with the thumb, then he shows with the fingers. That was his body language. Yeah, and you see where he touches. This is the most common spot for the herniated trigger point, the HDP in the hip, um, medial to the blood and nerve vessels. There you see how he touches with his thumb. And this is a very common injury. I think in Iran, soccer playing is very popular too. In Germany, of course, I know it best. My father was a soccer trainer, my soccer trainer. I played soccer all my life. Like all the young boys, they want to be a famous soccer player here. And this is a very, very common problem that I see in my clinic. Also, I have a lot of professional dancers in my clinic, and this is also a very common injury in dancers. This is one of the dancers that you she came to my home. It's a Japanese lady. And you see when she came to my home, because she told me, oh, I cannot move my hip anymore, and then she moved her leg, and I was like, I never got my leg so far in my life. That's a limited motion, okay, but for a professional dancer, okay. But I show it again and watch the difference between the sides. So that's the bad side, as you can see. And did you see the body language? Yeah. And now watch the good side, the normal side. She can move much higher, yes, and she doesn't bend. This is a dancer from the same. It's a National Theater near Hanover. She's an Italian lady. She speaks English. So what is this? What is she showing now? Is she showing HTP now? Yes, this exactly. This was pointing with one finger, exactly, and showing a line. Yes, exactly. Very good. Very nice. She showed the trigger band and the continuum distortion, which we will learn today. Very good. Ah, I'm proud. And now watch. I think the dancer, she doesn't even recognize that her body language changes. Now she changes from the right hand to the left hand. You hear it's tense and it's blocking her. Okay, watch it again. One finger by instinct. She uses one finger. Now she's showing a line, a trigger band. And now you see she changes her body language and the hand. Now she shows with several fingers. Yes, exactly. She has three distortions: continuum distortion, which we will learn today, the trigger band, and the HTP. Exactly. Very good scene. Yes. Now I have another example for you. This was he came to me last summer. I was on my summer vacation, so this guy called me. He's a professional dancer from, I think he's from Jamaica. He dances near Hanover at the State Theater. We have a lot of state theaters in Germany, so that's why we have a lot of professional dancers here. And he has this. So he told me, I should go to operation on my spine. So I will translate this for you. So he has mediolateral impingement. On the right side, the dural, how do you say, the dural sac is pinched, and S1 is pinched. So he has the disc, he has something like a disc hernia, and it pinches. You see he has a disc hernia in the segment L5S1. So he should get an operation, and this is a catastrophe for a professional dancer. So I treated him here in this room, and I will show you the video. Now we test him. To the front. How's that? Actually, this already hurts in the hip. Yes. Okay. What is this? He has pain in the hip, not in the back. And in the back, not? How's it when you bend back? Actually, this is okay. All the way? Okay, but it's pain-free, yes? Yeah. Okay. I mean, I feel a slight pinch, but nothing. Okay. Okay, a slight pinch on the, maybe a CD in the front, a slight pinch in the back. Yeah, maybe HTP, maybe CD. Yes, correct. It's like we had to test it. Yes, but actually only little in the back and a lot in the front. This is crazy. Yes. And put your feet together, please. So here you already see my test for the back, bend to the front, bend to the back, side bending. And do the side bending that you go with the left hand first down here on the side of the left leg as far as you can. How's that? Okay, very good. How is it to the right side? I feel more like it's trying, like I could go further, but it can't go any further. What kind of body language is this? Maybe, I would think so. Maybe HTP, maybe little trigger band, but this is kind of a difficult. Yeah, and no limitation. Yes. So this is kind of like surprising for me too. Okay, because like a block or something or holding you. Okay. So he feels like a block, but it's more subjective, not too much objective. Yes. How's it when you put your knee to the chest? You can, yeah, and you move it all the way with you. This one is good. Do you feel something now on the left side, or it's okay? Okay, good on the left side. Now watch. This right here hurts. Oh, what do we? This is the exactly. Okay, but you could see it, I think. Why not? In the hip. Now you hear me. I'm surprised too. He has pain in the hip. In the back, nothing. In the back, nothing. How's the other way when you do this? Yes. This way's okay. No pulling pain or something in the front. How's it when you do it on the left, on the right side? Sorry. Yeah. Yes, left hip is limited. And what is he showing? I think you could see it. He pushes with several fingers. Yes, exactly. This was an HTP. Yes. And so now we treated the HTP on the couch in my living room. Yes, hip HTP, correct. So now we treated it one time. And there you see, I don't have a treatment table here in my room, so I treated him on the couch. Looks better from outside too. Yeah, it's a lot freer. Okay. Okay, I have to say, I did one HTP in the back, but this was like 1 minute because he only felt a slight pinch. So that was an HTP and HTP in the hip. Now go and take your left knee to the chest. Look how that is when I do all this line. Is it even better too?
It's better. It's a lot better. I mean, there's still a little bit of a blockage.
Yeah.
Like I can't get it past here. But
Okay.
this is already a lot better.
But is it the pain that hinders you now? I'm sorry. Now I translated a German word into English, but he understands a little German. Hinders is like that blocks you. I just took a German word and put it into English. so I asked him if it's a pain that blocks him. To do it, or it's more like a stiffness, or
It's a pain. I feel is yeah. I feel pain.
Can you do the right side? Okay, so now it was better, but not good. So now we treat it again. Do it again. Flex the knee. Put it to the chest. This looks better now.
This is a lot better.
Do you hear his voice? Listen to his voice.
I still feel it a bit, but it's already a lot better.
Okay. Try the other one. Looks almost the same from the side. So what do you hear in his voice? What do you hear? Listen to his voice. Do it again. Flex the knee. Put it to the chest. This looks better now.
This is a lot better.
Ah, you don't hear it.
It's already a lot better.
Okay. Try the other one. Ah, okay. Ah, okay. The voice is so weak. Okay. So he says like it's a lot better. So he has yeah, it's a lot better exactly. So oh, I'm sorry, the sound is not. This is always a problem. So he has hope. So how does a professional dancer in the beginning of his 30s feel when he reads the paper from the doctor? So when we did the testing, did you see? And I asked him, did the doctor do those tests? And he said no. He just looked on the MRI and he wanted to give him surgery. And this is what I see a lot. Palpation is actually something like a red flag in Germany. I don't know about Iran, but here it's becoming really like a red flag. And he didn't do any testing, so he had big problems in the hip, but only slight problems in the back. And I mean, if you can touch the problems from outside, did he have any nerve radiation? No, nothing. He had only problems, local problems in there. So there was nothing that I would tell him you need surgery or something. So nobody tested him. So this is very important, to test the patient, to talk to the patients. And after the HTP treatment, the patients need no exercises, nothing. It's fixed or it's not fixed. You have to take the problem. Yeah, it seems the same situation in Iran, yes. So you have to take the problem on your shoulder. If you cannot fix an HTP in one treatment, it's mostly up to us, because maybe the positioning was not good, or your direction was not good, or maybe the force was not enough. Yeah, these are the three factors that I'm working on: mostly positioning of the patient and direction of my push. But a lot of times in my clinic, I'm now working with FDM for 14 years, and a lot of times in my clinic, patients have to come 2-3 times to treat it again. I cannot fix it with one treatment, or maybe they are fixed in my room, but then it comes back a little bit. So this is quite common. And this is what happened in a lot of my dancers. I have a lot of professional dancers, and I experienced one thing. So when they come with this paper from the doctor, so then the dancer is very depressed, because he feels like, how do you feel when you read your disc hernia? It's out, your dural sac is pinched, your nerve is pinched. Then you just feel bad. As if you don't know, you feel better. Yeah, but if you know it, you feel there is something. So when I treat them, they get hope, like this guy. And when it comes back, then they think, oh, it's my nerve. So that's why I'm always working that on the fact that I can fix the dancers with one treatment. Yeah. And in this guy, it stayed the same actually. He didn't come back. It didn't come back anymore, and he's just free. I didn't see him since then, so he's fine. But in some dancers, I needed several treatments. So I will tell you my 5 steps of treatment that I developed during those years, because I have to admit, I had a lot of patients that came back with the pain, and it depressed me too. It was a lot of pressure from, actually, I learned a lot with the dancers. So I will show some pictures of the treatment. And so this is the most common location that you see here, that you saw in the soccer player too, medial from the vessels, from the nerves or from the blood vessels. Yeah, I hope everybody can see it. This is a better picture. And here you see 2 things. So do you see the femoral? It's medial from the Kalisenglocke. Yeah, there's the femoral. It's medial to the femoral vessels. And then you see a lateral femoral. And this is also very common. I talked to my teacher, Dr. Hara from Vienna, and I told him, I saw it in so many dancers that they told me, Torsten, it came back. And then I asked them, and then they showed me another spot. And I see a lot of times that when the patients come first time, they show you here, media from the vessels. And then you make the retest, and then they say, it's still. And then you realize they are showing the lateral femoral. So please, if you have this in your clinic, always watch where they show it, because a lot of times you will see first they show it medial and then they show it lateral, but the patient doesn't realize he's showing you 2 spots. He's only feeling the blockage, the pinching in the hip, and not realizing that there are 3-4 centimeters between those spots that he shows. And a lot of times I make this topic in my clinic, and I tell them, now you're showing more outside, and then the patients say, oh, you're right, and they don't realize. Yeah, it's different from the C sign, but it can also be the C sign. So if a patient, mostly you saw now in those videos, the patient showed with the fingers or with a thumb, but it can also be that a patient puts the fingers around the hip and shows you with a thumb. Yeah. I saw this body language too. So you have to ask the patient, what are you showing now? Are you showing me the whole ring with your fingers, or are you pushing with your thumb? Do you feel only one spot? The patient will know. He will tell you. So a C sign where an orthopedic surgeon would say, oh, this is a pinching of the hip, can be also femoral HDP. And I wanted to show this to you in this seminar because this is a very, very common distortion that I see in my clinic. And in Germany, as I told you, we have a very good combination here in our seminars. We have half medical doctors and we have half physiotherapists, so that the doctor and the physiotherapist is working together, which is a very good model. We should try to get this for Iran too. And a lot of surgeons, if they are really honest, they are coming to me and telling me, you know what, this femoral HDP, I saw it 1,000 times and I always gave them a new hip. And then they are better after the surgery, but then they are going to rehabilitation. And in rehabilitation, then they are doing the leg press, and this hip flexion, it really pinches the HDP. And I saw a lot of patients with a femoral HDP that came worse from rehabilitation than they went in. And I see patients in my clinic, and this is not exotic. This is actually quite often that they have a new hip, a hip endoprothesis, and they tell me, I can move worse actually than before my endoprothesis. So the femoral HDP is a very, very common distortion, and it's like magic, as you saw now in this dancer. Yeah. And it just depends on your technique. That's what I found out. So I'm giving you my experience from my clinic because there were a lot of patients where it just came back. So that's how we developed this treatment. And now it's much, much better. So I found another factor according to those that Dr. Tupaldos had. I just pulled on the tissue too. And these are the 5 points that I do in the treatment. So first I pull the tissue inside, then I already do a test. And after the test, it's already, I would say, in most of the patients, 80% better. And the patient, if you're doing a retest in between, then the patient already is like, wow, he starts to trust you. And then after the pulling, I push. I push where the patient showed me, or a little bit more caudal, and then I push the tissue up. Then I treat the bullseye in the back, the HDP in the back. I will show you a picture in side bending on the table. And then in the standing position, I don't do this always, but sometimes I push the tissue inside. And yes, and they always have a tenderness. You can feel it, and the patient will tell you to. So I will show you the steps. So the first step, what I do is I push the tissue inside. Actually, on the osteopathy school, I learned this technique already, and my teachers told me that this is a technique for, I don't know, the psoas fascia, or or to get between musculus iliacus and psoas. And I just take it now. I go above the inguinal ligament. Yes, digging. It's like digging and then just pulling the tissue inside. This is very, very good. And when the pain, then a lot of patients, they lay, and I see they are somehow getting, skeptic, and they tell me, but Mr. Fischer, where you are pulling down, this is not the spot, you are above. And I'm telling you, yes, of course. And then I'm holding this for like 2-3 minutes, quite long. And then the patient say like, I think I feel it. When you're really in the right spot, then a lot of patients tell you, I'm feeling it, below the inguinal ligament. So first I'm doing it with my whole hand, pushing like this. If this is the inguinal ligament, I go above, I hold it, and then I go on the head, and then I just go inside and pull very strong. Sometimes this is quite painful. And after this technique, and after this technique, I do a retest. And then you will see, mostly I see really it's 50%, mostly 80% better. So after this technique comes actually the most painful part, the pushing. This is my colleague Nicola Unternehrer. He works for a famous football club in Switzerland, for FC Basel. And he, of course, he uses this technique a lot. And I learned a lot from him too, because he's always treating the same guys, the professional soccer players. And you see, he's pushing with his right hand, not with his left hand. So what I learned from him is that I started this technique too. I put the leg over my leg. So then his hip is more relaxed. A little bit of knee flexion is always very good. And then he started very, very low, because as you can see, the patient probably will show you, can you see my mouse? Yeah, here. So the patient will show you probably here, but where the arrow is, that's where I start to push. So I think that was one of my mistakes in the past, that I always pushed too high. So now I'm starting a little below where the patient showed me, and this is a lot better. And you will see that you will feel the tense tissue. You will already feel it below, and the patient will already have pain below. And now comes the next important thing. As you can see, the tissue has to be pushed towards the head. And I see a lot of therapists, they are working in the direction of the treatment table, but this is not the direction where the tissue needs to go. You need to push it under the inguinal ligament. So this direction of push is also very important. That's why you see my colleague, he's bending over. Sometimes I'm bending over even more, I'm like this and pushing it. And now he and the player, both, they are helping above the inguinal ligament, they are pulling. And you will see, if you start with the pulling too, then you will see that it helps a lot too. Yes, and you have to be careful not to push the artery. You know this, I learned in the medical or in my naturopath school, I learned this Ivan, internal vein, arteria, nerve. So always keep this in my head that I have the arteria there and I little bit go to the medial side to not push directly on the artery. Actually, we are not pushing down, we are just pushing up. But I'm making sure you feel, if I feel the pulse in the patient, then I go a little bit to the side. Okay. So this is what I'm doing with my patient, and I have to tell you, it works quite good. And now comes the third step. So after this treatment, I treat the HTP above the piriformis, mostly in the back, in the buttocks. So why I treat this? Because I went to a student of Dr. Tupaldos in the USA. I went there for 1 week to Marjorie Custon for hospitation, and I saw she treated this already in this condition. And then I asked her, but why are you treating in the back? And then she told me, because she worked with Dr. Tipaldos, she does FDM longer than me. So I was humble and said she will know why she does this. And then she told me, I saw there's a combination of this two HTP and the treatment is much better in the front. And as I had so many problems with this treatment, I said, okay, I will do this when I'm back in Germany in my clinic. And then I did it in a lot of patients. And you know what happened? A lot of my patients, in the moment when I pushed, they told me, yeah, it's in the back too. And then I asked them, why didn't you tell me in the first place? And they said, I thought you know. And I said, no, how should I know? There's something in the back too. So this is also one thing that I use in the FDM. If you ask the patient or if you just talk to a person, they don't feel their body as good as when you touch them. So now I'm always treating this, and I would tell you, if you push there, but the patient only showed you in the front, 80% of the patient or 70 will tell you, yeah, I felt it in the back too. There's some tension there too. So that's why I treat always the HTP in the back, above the piriformis, mostly in the gluteal area, and in the groin. I always treat them together. I mostly do it in the side laying position, and then I tell my patients a lot of times, please relax your leg, or I pull their leg, or I tell them just to play with it, and then I just push the tissue, what you see there, hernia suprapiriformis, I just push it under the sacrum. Yes, this is my direction. Yeah, I'm trying some Farsi language, but my teacher always tells my teacher told me one sentence in Farsi. She told me I'm a lazy student, and ingushtar vaze. That's me. She said I should learn this sentence. It's very hard for me, but I try to get better Farsi. But I think I will not be able to give you to give you a lecture in Farsi. So there you have a bigger picture, and it feels too like an almond-like feeling. And for physiotherapists, this is always ISJ blockation, piriformis syndrome, and whatever. And you can treat it just by pushing this tissue under the sacrum. That's a very common issue in the femoral HTP too. And then comes the fourth step. I have to admit, I don't do this always, because in the dancers, they are very small, but sometimes I have some really big guys, and I think some of you follow me in Instagram, and you saw I have some bodybuilders and strongmen too. And this technique is very hard to do in them. And they have it a lot of times too from the squatting, they get blocked here. And then when the bodybuilders, when they have their competition, they need to stand like this, and they cannot because they have pain here. So I see this is a common injury in people who do a lot of squats too. And for me, it's very hard to lift the bodybuilding guys. So you can do it also. I'm doing it like this. I'm taking the fist, I'm putting it above the inguinal ligament. And because if you take the fingers, it's too much pain for the patient. So I'm pulling the tissue up. And if this is the HTP here, yeah, my shirt. So then I'm, I'm pushing it like this from here. So I'm really pushing it, and the patient, like you saw in the soccer player, the patient is just shaking his or her leg. This works kind of quite good too. And then I give my patients always some self-treatment for home. So they should put something under their knee, that their knee is flexed. um, how long do I pull it in standing? Maybe 1 minute, 1 minute, 1 minute and a half. And the patient at the same time is shaking the leg like the soccer player. And then I tell my patient, please, when you lay in bed in the evening, please put something like the pillow or the cover, put it under your knee so that your knee is not extended, just a little bit flexed, and then pull the tissue inside. And I have a lot of problems with my patients because most of my patients, they are not digging, they are just pulling the skin. And it's so hard for me to explain this to my patients. And this is on a seminar in Munich here. And this colleague, she told me, I told my patients to take a bottle or something. And then when they lay, they should take the bottle and push the tissue up. And I told this my patient, and it works very good. And since I tell my patients, please, the next 4 or 5 days after my treatment, always in the evening when you lay down, put something on your knee and pull it inside, even if it's good. Please do this at home. And most patients do that. It takes them 1 or 2 minutes. It works very good. I have less recidives in my clinic, and I can mostly finish everybody with one treatment. But it was hard work to develop this 5-step program. And if I'm doing a retest after this last technique where I pull inside, and if it's not 100% good, then I'm doing the 5 steps again. I don't know. Mostly I hear in Iran you have like 40 minutes, 45 minutes, yes, and it's good to have 45 minutes for a patient like this. Then you can do it again and again and again. Yeah. Yeah, the point of pull is, yes, the point of pull is above the inguinal ligament. Yes, I will show you this picture again here. I made the arrows above the inguinal ligament. You see, so the HDP is under the inguinal ligament, and we just push it from above. Yeah, I always push in laying down, then I always pull and then push, because the problem is the pushing is quite painful in the groin, and a lot of people are this is a sensitive area, so you can prepare it a little bit with the pulling inside and then with the pushing, then it's less painful for the patient. And I mean, it's not a very common area where you let somebody touch you and then you prepare them a little bit. And when you do the retest after the pulling and laying down, a lot of patients already see, wow, this is a lot better, and you will have a lot of trust. They will trust you, they will calm down, and then you do the pushing. If a patient, when I push, when I do this technique, when I push and the patient is too tense, then I tell my patients, please pull your scapula together, and then they have to relax as a reflex, then they will relax in the groin, and then I push harder. But this trick only works once. He will not trust you or she in the second time. But this is my 5-step program for the femoral HDP. And I can just tell you, this is very good in an online seminar. And this is, you can use this very good in your clinic. And if you have any problems, I will give you again my phone number. For those maybe who didn't write down, you can send me a video or give me some questions. I think I answered everybody now in Instagram and in WhatsApp. Okay, is this clear? Yeah, I let the other hip extended, but you can also flex it if you want to. But I mostly extend it. I like it with one leg flexed, and then I just push. Okay, then I wanted to tell you about another distortion, the cylinder distortion. Um, this is what is neurologically interpreted. We saw last time, I think we saw this lady, yes, from Africa, with a knee problem. And you see the invisible cream that she uses. I say always she uses invisible lotion to put it on her knee. So we here, I think we saw her in the last seminar too, the lady from Russia, from Khabarovsk, who had to always stabilize her handicapped daughter, who does everything with the right hand, and with the left hand, she has to take care of her disabled daughter, who's physically and psychologically disabled. So she needs a lot of help from her mother, and she does not feel her left arm anymore, which is very bad. And you saw the invisible Russian lotion, yes, that she uses. She puts it on her whole arm. She doesn't show a line, she doesn't show a spot. She just puts an invisible cream or invisible lotion on her arm. And you hear the translator, because I don't understand Russian. Sometimes she could not feel her arm, which is very bad, because she needs to take care of her daughter. And now what does she show in the back? Ah, okay, and here, yes. Yeah, and then she shows, what does she show in the back? The line. Yes, she shows two lines, trigger bands. Yes. Okay, here you see a lady. This is in my clinic, and she has she says she has electricity in her legs, and she has how does it say, like a tingling. This is called restless legs. I think you all know it. Yes. She says kochend heiß und Strom drin. German is such a hard language. She says it's like a cooking water and there's electricity inside. And then I touched her leg. There was no electricity and they were not hot. So this is all subjective. And she has tingling and they're nervous at night. So this is restless legs. So please take attention now. Pay attention to the last gesture she makes. You see, she shows something outside her body. That was the first patient that you saw now, or the first patient videos where the patient shows something, but not on his body. Yes, so this is what you will mostly see. Sometimes when you need cylinder techniques for helping a patient, this patient will not even show you on his body. These patients who have a neck pain. If you have a neck pain, a cylinder, sometimes some patients tells me it's like a cat mother, grabbing you in the back, but they don't touch themselves. They tell somebody's grabbing me in the back. If you have an HDP, the patient will tell you and show you. But sometimes in the cylinder, you see the patient doesn't even touch himself. Here you see a patient, he has a tingling. This is like a vibration or a tingling or shaking. And interesting is also that he makes a sound. I hear a lot of times when patients make some crazy sound, like does he make? And I'm always telling them, don't do this when you go to the doctor. He will, send you to psychiatry. But you will mostly hear also when patient describes their distortions that they make some sounds. And when they make crazy sounds, that's mostly cylinder distortion. And you could see the German lotion now, yes, that he uses always from the middle to the periphery. So he shows us already how to treat from the middle to the periphery, not to the center. And when I look on Instagram, I see a lot of pictures also from some Iranian physiotherapists, cramps and restless legs and whatever. I see a lot of cylinder pictures actually in Instagram. Sometimes I make some comments, but nobody seems to understand them. So this is the cylinder distortion. So again, for you, the first one is BL, is body language. So we have a squeezing of tissue, a rubbing or sweeping of tissue with the palm, or sometimes the patients will show you areas of complaints. So never a spot. SC is subjective complaints. Mostly patients will say it's a pain deep inside, it's an area, a region, and this is not always pain. It can be also in German. I don't know if you say it in Farsi too, but they say, my arm is sleeping at night, or my hand falls asleep. Yeah, and it can be numbness. In carpal tunnel syndrome, a lot of times, you have this body language that patients rub or squeeze their fingers. Um, Sometimes they tell you the pain is jumping. That's why a lot of people think they are crazy. Then they will tell you, yesterday I had pain here, today I have pain here, but the week before there was a pain and a cramp here. And that's why these patients are mostly neurologically or psychosomatically interpreted, because people think they are a little bit crazy because the pain is jumping and they have tingling or ants running down their arm or water running down the spine or whatever. Yeah, that's what I think these patients need us very, very much. Yeah. Das Tam Kapmira. Okay, yes, okay. I have to learn this, Jab Mira. Okay, I have to learn this. Um, Objective findings. You see, this is a very small. We see that we don't see nothing. Yeah, pain is, yeah, a variety. Pain is not always there. Sometimes tingling, sometimes ants running, and they have no pressure pain. You can touch them, but they have no pain. What I see sometimes is when I pinch them, oh, they are very, very sensible. I see it in my seminars too. When I show some pinching techniques, oh, I see a lot of therapists, they have a lot of pain. Pushing, nothing. Oh, but pinching is very painful. So I use this sometimes as a test in the clinic. And sometimes I see they have lack of motion, but not always. Today, for example, I had a lady in my clinic. She had HTP, and then she could turn better, and then she did like this. She was squeezing her tissue, and she said like, it's still, what did she say? Verspannung. There's some tension in here. So then I grabbed like a cat mother, I grabbed this and let her say no, 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 and after it was better, and she can turn some more. Sometimes I see some lack of motion, and uh, a lot of times I have patients, we we don't know why they have it. I see it sometimes after an orthesis, after bandages, after infections. Also in Germany, we have big problems with resistant bacteria in the hospitals here in Germany because of the privatization, because the cleaning of the hospitals is not so good anymore in Germany, and we have big problems with those bacteria. And I have a lot of patients after knee arthroscopy, and they still have such a crazy pain, and it's mostly cylinder. If you have a flu, then you also, you have this feeling, oh, everything is painful, and this is also some kind of cylinder. So I see it in infections too, but I have to admit, I see a lot of patients, we don't know why they have it. Yeah. And Dr. Tupaldo's imagination was that the spirals of the superficial fascia, they are a shock absorber of the tissue, and they coil whole areas. So those patients, that's why those patients always complain about an areal or a region, and those coils are twisted. I always like to use those phones, and I imagine those coils like this. When you have it here, for example, that they are just twisted. And that's why the patients, they don't have a body language. The patient treats himself. He tries to do this, he tries to fix it. And some patients cannot fix it, so we have to do it a little bit harder. There's a French surgeon, Dr. Professor Gimbertot. I don't know if I showed you last time some examples from his works. He's the only one on this planet who has a microscope, who has an endoscope, and puts it into living fascia. He has fascinating movies of fascia. I think he made 5 movies so far, and he can show how fascia is moving. And I saw him 2, 3 times on some congresses. He was on the Fascial Distortion Model Congress 2 times too. And we asked him, what do you think about the cylinder fascia? And he said the same. He calls it, as you see there, the name, microvacuolar collagenic dynamic absorbing system. And he said, yes, the cylinder fascia, this is really the crazy fascia. This is the tissue which is moving, which has a lot of proprioception. And I'm showing this sometimes to my patients, because a lot of times my patients think they are crazy, but I show them, I say, no, no, there's one guy on this planet who can make it visible, but we don't know nothing about this tissue. And I will show you now an example from him. And please watch how complex this is, how much it changes.
Nous ne faisons qu'entrevoir la complexité du mécanisme et résumer des glissements à une adaptation entre filins et matures, le tout sous un ordre prédéfini par des mathématiques même fractales, nous semble insuffisant pour tout expliquer. D'autres facteurs ne sont pas admis. Il semblerait tout d'abord que les fibres possèdent en elles, par leur organisation moléculaire, une capacité à la distension ou à la rétraction intrinsèque. Une étude attentionnée permet de conclure à des superpositions annulées intrafibrillaires qui se distendent avant le mouvement plus global. Il semblerait que ce soit la première étape pour faire face à la sollicitation. Pour répondre à l'orientation de la contrainte, la biomécanique de
Did you see it? How complex is this? Now watch. It gets even more interesting. Now watch the next sequences. Yes, and this is also kind of fibromyalgia, morbus Zudek, and yeah, this is all the crazy stuff is actually cylinder.
icosaédron est suppléée aussi par une capacité supplémentaire de la fibre à migrer autour d'un point nodal le long d'une autre fibre, comme une sorte de charnière mobile avec distorsion angulaire créée par une force supplémentaire de cisaillement. Enfin,
And now watch this. Watch. There's constantly this tissue is constantly, it looks like it's ripping off, but it's making new junctions. This tissue is so complex.
il existe cette capacité à la scission soudure du collagène, surtout 4 et 6, à se dilacérer.
Did you see it? It opens in the middle. Nothing is ripped off, nothing is broken, but there are constantly new connections between this tissue. Yes, yes.
Se recomposer immédiatement à d'intégrone, mais aussi à se dissocier en plusieurs parties, comme les hydres de l'Antiquité, répondant à la demande à toutes les sollicitations mécaniques de l'espace. Cette capacité de la matière et son organisation spatiale offrent des potentiels de mouvement infinis.
So this tissue is even more complex than a spiral, but we are using the picture of a spiral to work better. And when you do I will show you the squeegee technique. And when you do it, I see some spirals. And sometimes patients say this too. I think this was how Dr. Tupaldos developed the picture of a spiral. But I asked Dr. Gimberto. He's a very nice guy. If you see him, he's very open-minded. He always comes with his wife. And I asked him, do you see do you see something like an X-ray? Do you see something you could categorize? And he only laughed. And he said, no, of course not. And he told me a very surprising answer. He told me, we humans always need to categorize this to understand this, but the nature doesn't need it. Yeah, we need to do it. Yeah. And he said, no, I don't see nothing. And yeah, it looks like glue and it doesn't rip off and it's totally complex. I don't know if it could be torn. Actually, it's a good question. I don't know. I saw also Professor Gimberto. You can write his name on the internet, and on YouTube you will find some excerpts from his videos. Somebody made some copies, not the whole video, just a little excerpt. And he also made made a video with an endoscope which he put inside of scars. That's very interesting too. So this guy is really cool. He makes a lot of stuff visible, and he told on a congress he's doing those videos because he wants to change the imagine in surgeons, because he said, surgeons are still thinking the same like they did 100 years ago, and I want to make surgery better. So this is a really really cool person to watch. And he gave us very, very interesting images. What is interesting is that he calls this tissue microvascular collagenous dynamic absorbing system. So he says too, this tissue, this has also an absorbing factor, how it functions. And I will give you a good example for it. I think the most of you know the Stecco family. It's an Italian family from Padua. The daughter is a very, very famous scientist. The brother is a therapist, and the father is a very, very famous anatome. Very, very. And the daughter, Carla Stecco, she just wrote a book about fascia. And I wanted to show you two of her pictures from the fascia under the skin. So I think the superficial fascia, what you see here, the first layer of fascia, this is the cylinder, and maybe the second one too, or the second is the trigger band. I don't know. But I see a lot of times if patients have very dry skin, or when patients have lotion on their skin, the cylinder technique is not effective. So you need to come under the skin. And that's why I never use oil for the cylinder techniques. A massage would be a cylinder technique for me too. But if you use oil, you're just slipping over the epidermis. You're not coming under it. You're not correcting this superficial fascia here. This is the picture from the dissection. There you see it, under the fat, under the superficial fat, there you see the superficial fascia, and above the muscle, you see the deep fascia. And you have to come under the skin. So that's very important. So if sometimes patients have dry skin, I put some water, I rub it dry with a towel, and then it's good. But if they have lotion, I rub the lotion off and never use any oil, because you need the resistance to come under the skin. So you could say, now, after this online seminar, if you have a patient where you think, oh, I think this patient is crazy, then you can be sure he or she has cylinder. You can say, if you think the patient needs to go to psychiatry or on the couch, cylinder. I think some of you saw it in Instagram. There's a book now from an Austrian psychotherapist. He's quite a famous psychotherapist in Austria, and he's treating patients with facial distortion model, because some patients, they can express their depression or their anxiety with their hands. So he keeps asking them, where's your anxiety? And they say mostly here or here. And then he uses cylinder techniques. Sometimes they have even HDPs, and he treats also patients in psychiatry with FDM. It works very, very, very good. Yeah. And I think everybody knows Frank Natter. And this is from the book of Frank Natter. This is neurology. And here you see patients, there's in German, patients complain about strong pain that is jumping and which goes everywhere. The guy in the brown trousers, he's writing aggravation, dramatizing of the pain. In the middle, you see the guy, LASIK test is negative. So this for Frank Natter, this is in German, the psychogenic back pain. You see, Frank Natter always thought the problem of the patient is between the ears. But you see, he described so good. You should just change psychogenic back pain and write cylinder distortion. That would be all, Frank Natter already saw it, but he could not categorize it. So now we have a categorization, and you will see your patients are very, very happy, because the patients feel that everybody thinks they are crazy, but they have really something. So how do we treat them? By manual therapy. It's very easy. So for example, if we have a patient who has a cramps and who does like this, who shows you like this, then I'm doing the same. I'm using my hand and I'm just going down the leg, for example, or the lady who had restless legs. I just follow this pathway in the direction the patient showed. And I'm using always here with my forearm 45 degrees angle. Just go down, maybe go onto the feet. If you have some patients who have this in their arm, I'm doing the same on the arm. I let the patient put the hand here and tense the muscles, and then I just follow this way through until their fingers. This is the most common technique that I use in the cylinder distortions. If the patient, for example, shows me cramps like this is, yeah, then I use a clamp or I use the pinching. So I'm treating the patient actually in the same way which he showed me, because I think humans, our patients, do not show nothing. They treat themselves. This is their instinct which tells them what to do. So this is what I use in my treatment. And this is a woman that went to psychiatry, and I, podolog, the people who work on the feet, her podolog sent her to me because she cannot walk. She has breathing problems and she cannot walk anymore. So she is in this condition now for 2 years. Now look at her.
Gehen Sie mal. Das ist unsicher, ne? Warum? Wo tut's weh jetzt?
You see it? I ask her, where you have the pain? And now she says, oh, here down the legs. And she complained about some, how do you say, some cement or heavy legs, And now what you don't see is she did also this. She went down her legs, but she was also squeezing her legs like this.
Ja. Und hinten im Rücken auch?
And now I ask her, and how is it in the back? And look now, it looks like she shows a region, but she's showing a line with her thumbs.
Und da hinten? Okay, da alles. Können Sie ein bisschen flotter?
So I will tell you, she has 2 problems. She's using a lotion in the front. That's why she has heavy legs. And because she's like this is the problem of the trigger bands that she's showing, and you cannot hear it because the sound is too low, I think. She's breathing like this and nobody knows why. That's why they think they looked for Parkinson, multiple sclerosis, and whatever. They did MRI of her spine, her head, but nothing like this. So she has no structural damage. Something is not working correct. Yeah. And this is the medication that she gets every day. I don't know, you have Lyrica, you have this in Iran, this medication? This is actually against depression. Yeah. So she's a junkie. She takes Lyrica for, I don't know, 2 years now, or 1.5 years. They gave it to her after they let her off of psychiatry. Makuma, because she had some thrombosis in the leg someday. The rest of the medication you see on the left side is all for neurological disease. Then you see she has diabetes, metformin, and she uses this medication every day. So why did the doctor give her this medication? Because what does he think? I think he doesn't think she has a mechanical problem. Yeah, she has a spinal stenosis. No, they looked for it. Diabetes. She has diabetes. Yes. Yeah, he thinks she's crazy. That's all. She has she has neurological pain. She cannot breathe, she cannot walk anymore. So if you do, as a doctor, you do an MRI of the head, you check the blood. She has diabetes for decades, so that's not new. But somehow she has legs that are heavy and all of this. So after this medication, this patient knows that the doctor thinks she's a little bit, maybe, not so in her head. She has a head problem, but not a body problem. So it's our job to bring this patient back and show the patient what you're feeling is right. So what am I doing here?
Genau, ein bisschen flotter.
Do you see the clamps?
Ja, ja, super.
So what do you think now? What do you think this patient thinks now of me? Huh? Now finally she thinks I found somebody who's more crazy than me. This doctor is totally out of his mind. He puts clamps on my leg. Finally, I'm not the craziest one on this planet. I found somebody, thanks to my podolog. But now watch how she walks after I take the clamps off. Watch her.
Ruhig ein bisschen flotter.
Ah, it was not so painful, the clamps, but how does she walk now? How's this? Do you see it? You see still the clamps?
Hoch.
It's better, yes? Yeah, it looks already better, yes? When you look how she came in, she walked like this.
Gehen Sie mal.
And now after the clamps, even with the clamps, she's walking better. But still with the clamps, it's a little bit, yeah? And now watch her. Yeah, I pinched, exactly. I pinched the tissue. I pinched the tissue and it was a relief for her that somebody pinched the tissue. So now watch the patient. Now she goes to the right side. Did you see it? And now we are seeing the trigger band because the trigger band makes weakness to the side. So now I treated the trigger band. There's another colleague in the room. And now we let her run already. You see her hair, she's already finished. After 2 years, she did not run.
Und?
Now, do you see her right hand? She still touches herself, yes? She still touches herself, so she needs some more treatment. But for the first treatment, that's not too bad. So what does this patient think? She thinks if like a crazy German FDM therapist puts a clamp on my leg, then there must be something, you know? If a therapist puts such a big clamp on your leg, then there must have been a problem. So she trusts herself anymore. Yeah. And I bought this instrument actually in a toolbox store. Sometimes my patients ask me what kind of crazy tools you have there, you know. I think if some clever doctor finds out you can use it for medical reason, it will cost much more. But this is still not too expensive. So I can give it to my patients and they can treat themselves. Good question with the breathing. No, the breathing was not better after the cylinder treatment. She showed this, yes? You see, she showed this line down. The breathing was better after a trigger band. This was very crazy. I have to admit, that was the only patient that I had in all those years with those kind of breathing problems. And this breathing problem was really gone after I did the trigger band, which gave her more stability in her legs. It went from the lumbar spine to the thoracic spine. Then it made a turn and went down the leg. Don't ask me how she developed this trigger band, but she told me to follow this line. I did it and it was much better and the breathing problem was gone. I don't know how, but it wasn't interesting for the treatment anyway. So I think everybody knows Edgar Allan Poe, yes? And Edgar Allan Poe, he has a very nice short story about chess. And in there he tells like that it's a human, very, very common mistake, not an unusual error, to what is complex we take as profound. And this is, I think, in this short story, Edgar Allan Poe described the cylinder without knowing it. So a lot of doctors tell this is neurological, like polyneuropathy, morbus Sudeck, fibromyalgia, migraine, and what restless legs or whatever, you know, cramps or all this kind of stuff. And this is all cylinder because I think every doctor. Today I had a lady, a patient. She has how I don't know if you have a dissociated leg. She drives in the metro, in the subway, and then she just collapses because she has no connection to her leg. And I did cylinder to her, and she came today for the second treatment, and she told me, I didn't fall anymore. I don't use a crutch anymore, but I feel like, she said it today, I have cement in my legs. So I needed to treat the legs. And they always told her it's a dissociation problem because she has a mental problem or something. But this is truly tissue problem, and the patient showed it for decades, for hundreds of years, and nobody listened to the body language. This is actually the main problem. Yeah. And you don't need any other treatment. Actually, you just need the cylinder treatment because this is new. I mean, did somebody tell you before to look at the body language or to treat according to the subjective complaints or body language of the patient? No. Yeah. Kali Kardan. Okay. Yeah? I will show you a self-treatment from a patient here. This is a patient, you see the little scar. He had a disc hernia operation. He came to one of my seminars in Switzerland, and he had a lot of pain, and we treated some trigger bands, all this. And now he has a rest of pain. That's why he came to this clinic here, and my colleague filmed him. And now he's showing his self-treatment.
Dass du besser geht, wenn du das hast.
Please do what you make to get better. So, does everybody see the difference to the HTP in the body language? HTP, this body language. Trigger band, this body language. And they would always do like this, but in cylinder, they squeeze the tissue. And this is what you see a lot of times when patients do this as self-treatments. Maybe a patient will tell you, I cannot sit because I have pain. I'm feeling like I'm sitting on my bone. And then you touch their tissue, and they don't have less tissue on the right side because the cylinder is the absorbing tissue is the shock absorber of the tissue. And this is what the surgeon, this Professor Guimberteau, what he says too. It has a shock absorbing function, this tissue. And if you treat it, you could treat it this way. You pinch the tissue, and 3-4 minutes, just let the patient move. Or a lot of times I use cuppings. I put cuppings on those patients, and I just let them move. Yeah, I put these cuppings on there and leave them on there for, I don't know, 5 minutes, 3-4 minutes, and they can move. The left one is a dancer, and the right one is a normal patient. And for example, these cuppings, this way of cupping, I use in this body language. When patient make this, and say maybe after long sitting, they have a pain here, and you cannot touch the pain. They feel they have some tension. Then I always like to use those cuppings. Yeah. And I see a lot of videos from therapists, they use hijama or cuppings just in laying down. But I can tell you it's more effective, the cylinder treatment, if you put the cuppings on and the patient moves. Yes, the patient can flex, the patient can do side bending, the patient can do hip flexion. I think it's just important that the tissue moves under the cups. The correction is done by moving, not when the patient is just laying down. And because the cylinder distortions are so bizarre, that's why I use a lot of crazy tools, like needle mats, clamps, the kiwi extractor, that's the suction pump for the babies. Yeah. I use it a lot of times too when patients show me in polyneuropathy for the like this. Then I use, for example, the kiwis or some other cuppings or some finger rings when they have a carpal tunnel syndrome or they have just numb fingers. Yeah. And if you have, for example, runners, I have a lot of triathlon or marathon runners, and they have a lot of times this body language. and then I tell my these patients to buy some cuppings by themselves. You can buy some cuppings. They have something to prolong it, so they can put it themselves on there, and then they can just do the cupping and move. Yeah. I think self-treatment is very good in cylinder, so that the patient just feels that he gets some self-respect. You know, that the patient feels, I'm not crazy. I really had something, and I can treat it myself and influence it. And it was just hard to categorize. Yeah. Yes, yeah, it's hard to believe. I can imagine that somebody doesn't need exercises. Yeah. But yeah, it's like this. It's what I see in my clinic. And if they have still something, you can tell them, just pinch yourself or just buy yourself some cuppings and then treat yourself. Yeah. And the pinching, for example, I do it like 2-3 minutes. Yeah. And then I do a retest. Maybe I do a lot in standing, not in laying down. And then I do the retest, like bending forward, bending backward, whatever hurt the patient. I'm doing this. And then I ask the patient, is it better? Do we need to do some more? Yes. Sometimes I see that some patients, maybe you have, I will show you the continuum distortions now. Sometimes I have patients who have pain here. Yes, painful arc, continuum distortion. Then I press, and then I see sometimes patients get better up, but they have pain in coming down. And then maybe when I do some techniques where I need to push inside the tissue, then sometimes I pinch the tissue and let the patients move. So they have some relaxation of the tissue and they have a better proprioception after. This is also how I use the cylinder in my clinic. And what I see, what is bad after cylinder treatment is heat. Heat is very bad. I even see when patients come very acute into my clinic with a very acute cylinder, then they used heat. Because I don't know about Iran, but in Germany, most people think, but heat is always good. And even my patients tell this to me, but heat is always good. They tell them, no, not always. In a cylinder, it's not good to use heat. And sometimes patients use it not by instinct, but because their grandmother or somebody else, tells them, use heat. And then they use heat, and then the cylinder explodes. So even after the cylinder treatment, it's very, very important. Tell your patients, don't go to the sauna, don't put heat on there. Just please don't do it. And some of my patients are really addicted to heat. Yeah, I see you know it. Yeah. And you know the grandmothers too, as I know. Okay, is it clear with the cylinder? Can you already remind some of your patients? You want to call some of your patients already? Okay, then we will start with the next distortion, the continuum distortions. Patients, who knows what is the cause for these distortions? Who knows it? Huh? Yeah, many clients come back, but because I didn't treat correct. I mean, there are only 3 ways. Your diagnosis is wrong, your technique is not effective, your technique is not good, or these patients have no distortion. They have a tumor or they have a biomechanical problem. No, I don't see any connection to the posture. I don't know if I have, everybody's posting now about the texting, yes, that it makes neck problems. But I have a lot of my CrossFit guys. I have a lot of very muscular guys who don't use this, who have also neck problems. So what should I tell them? Yeah. So that's why I'm always I'm very, very humble and careful when it comes to tell my patients something that I don't agree with. I went to the clinic of Dr. Tupaldos after his death, and his colleague told me, Dr. Tupaldos worked in a center for doctors, and always when a new medical doctor came into the clinic, they went for dinner in the evening. So Dr. Tupaldos went to the new doctor and asked him one question. And the colleague asked me, Torsten, what do you think? What kind of question did he give the doctor, Dr. Tupaldos? And I thought maybe if he knows facial distortion or body language. No. She said, the colleague, she said, Dr. Tupaldos, ask every new doctor, do you lie to your patients? And you know what every doctor answered? Yes, every day. And I don't want to do this because I see the same problems in people who are a lot on the phone. I see the same problems in people who are vegan, who are German, African, Iranian. I see everywhere the same problems. And I don't want to lie to my patients. If I don't see this connection, then I don't tell this to my patients. That's why I don't work on this, because I don't see there's a connection. I know that everybody wants this connection, but I think it exists in the brains of therapists, but not in our patients. I'm sorry. I'm not immune to this. I'm making myself some rules too, but then come 3 patients, they break everything that I just make up. So that's why I'm not using this stuff. And I'm not telling my patients that they always need to do exercises, because they will not do the exercises anyway. That's it. And then sometimes I have some patients who went to the physiotherapist before, and maybe it's a 70-year-old guy, and I ask him, why do you have this pain? And he stands and he's like, I didn't make my exercises. And he's so ashamed, and he doesn't want to do it. I think if you know an exercise is good for you, then you will do it. But don't tell your patients to do something that they even don't want to do. Trust the instinct of your patients. They will know what to do best. Yeah. If they like soccer, if soccer running is good for them, they will do soccer. Yeah. If they know stretching is good, if they have trigger bands, they will do it. But if they don't think it's good, then they will not do it. That's what I see in my clinic, and that's why I don't give them exercises or anything. And even when my patients ask me, what is the best mattress? What is the best pillow? You never know. I have a lot of patients that here we have a company, it's called Tempur. A pillow costs about 200 euros. And I have so many patients, they buy this beautifully shaped pillow and they have so much pain after sleeping on this pillow. And then they take their old pillow and they sleep like a baby, So what should I tell them? Yeah. I see. And even with mattress, it's the same. I have some guys who like a hard mattress, some like a soft mattress. This is so individual. I think there's no rule. And the problem is, if we as humans, as therapists or scientists, if we make rules for planets or we make rules for trees, the trees is not interested or the planet is not interested in what human talks, and it will not affect them. But if you make rules for humans, humans will always try to be the standard of what we write in Wikipedia or anywhere. And this is the problem. And I see so many people who don't fit in this. This is very individual, our job. And what I can give you with a facial distortion model is to treat the instinct of or to take the instinct of your patients. And you will see you will have so many happy patients because they're very happy with this, because they feel you don't need to convince them, because you understand them really, because it's what they feel. So I think what the patients feel is already correct. So I show you another example of a nice body language.
Wo der Schmerz war, wo der Schmerz jetzt gewesen
I ask her, where's the pain?
ist, irgendwo hin.
And I ask her, do you have some radiation? No.
Genau da hinten auf dem Haken gewesen.
So what is the orthopedic interpretation of this? Exactly, heel spur. Yes, exactly. Yes. So next patient. Plantar fasciitis, maybe 2, yeah. So what is the interpretation of this? Yes, tennis elbow, epicondylitis, Yes, exactly. This is the tennis elbow. This is what we see in golfers. No, this is actually a normal lady. This is one of the dancers. We saw him in the last seminar.
Show again, where you feel it?
So I asked you already, yes, what is the interpretation? Yes, This is the continuum distortion. Yeah, rupture, bursitis, painful arc, supraspinatus, impingement, oh, ACG problem, yes, there's a lot of orthopedic interpretation, but only one interpretation in FDM, what makes our life just easy. This is a friend of mine, and I'm this is the MRI, and the MRI says he has degeneration and rupture of the of the medial meniscus. Look what he shows. Do you see where's the joint and where he shows? One spot. Do you see where's the joint? Do you see any problems on the joint? Everything outside, yes? Yes, continuum distortions, exactly. But the MRI said something different. So this is what we see in those patients. The body language is showing with one finger, one spot of pain. And now this is very important. You will hear a lot of times from the patient that the pain is like a knife or like a needle. It's a stinging pain. And a lot of times the patients, as I told you, they make sounds. And a lot of times I hear in the CD, the patient does something like this. So if you hear this sound, mostly it's a continuum distortion. And from the objective finding, you will find a spot where it's very, very painful to touch, and it's directly on the bone. And mostly in the mechanism of injury, we have external forces which excel the ability of the transition zone to compensate external forces. So this is a very complicated sentence. I have to explain this. I know that in Farsi it's the same, in English it's the same, in German it's the same. We talk of the ligament bone transition zone as insertions. This is a problem because the language forms our thinking. So if you talk about an insertion, you think something is really inserted. But as many of you learned embryology too, you know that in babies the bone doesn't grow and then God puts the ligaments on the bone. Yes. So we have a transition zone, yeah, between two tissues yet emerged. And Dr. Tupaldos, he described ligament or tendon as water and the transition zone between as slush, so as a mixture of water and ice, and bone itself is ice. So if you have a one directional force, this is more in the osseous configuration. So it needs to hold, it needs to give stability. But if you have another force to another side on the transition zone between ligament and bone or tendon and bone, then you need flexibility. So he said it must be more in the ligamental configuration. And if you have a quick force to one side, then it can be pulled out, and then we have a problem which we feel here directly on the bone. It feels mostly like the tip of a pen, you know what I feel in patients, and we call it a continuum distortion because it blocks the ability of the transition zone to differ between the states. Dr. Tupaldos, he wrote 93, 94. He wrote some nice papers for the American Academy of Osteopathy. And I can show you a picture here of one of those. You see here, the first one, normal continuum. This is a microscopic picture. Do you see above is ligament or tendon and below is bone? So do you see the fibers running into the bone? And the second one, this is a picture which drew an artist, a painter for Dr. Tupaldos. This is how Dr. Tupaldos imagined a continuum distortion. That you have certain areas where the ability of this transition zone to slide is blocked. So that's why the patients have, if you have like pull in one direction, a lot of times you see in the clinic that the patient has pain in only one direction. For example, distal radius fracture. The patient show you one spot of pain. So he can move like this, no pain, like this, like this. When he goes up, he has a stinging pain here. And a lot of times I think my patients, they forgot about me because they look long time, they look where's really the, where's the level of pain. Now, and then they find it, but every other level is okay. It's exactly in one position they have the pain, and this is very characteristic for the continuum distortion. Dr. Tupaidos, I don't know about this, the cyst in the wrist. Actually, I saw some of my colleagues, one of my colleagues had it and another colleague treated him, and he did a brutal continuum technique and a trigger band technique, and then I think he broke the cyst. But that's what doctors here, they smash it with a book. I don't know. I treated it and I was not successful so far. I think I only broke the ring and then the fluid just went off. I don't know what its cyst is. This is kind of a difficult condition. And any tendinitis, actually, biceps tendinitis, supraspinatus, levator scapulae, yes, it's mostly CD. Yeah. And the doctors, they always give steroid injections and they help a lot of times because do you see the second picture here? Do you see this? You see my mouse? Wait, I will make it a little bit bigger. Here. And I think the cortisone pulls the osseous components into the ligament and then he fixes it sometimes. So I see continuum distortions are sometimes healed by steroid injections by doctors. But the doctors always tell my patients when I ask them, what did the doctor tell you when you give you this steroid, this cortisone injection? Oh, it's because of the inflammation. I don't think the inflammation is the problem. The continuum is the problem because the patient has the continuum. That's why the body tries to heal it in a biochemical way, but he cannot. And when we fix it, so the architecture is wrong. The architecture is the problem of this continuous biochemical problem, of this inflammation. You see it, for example, in Jumper's knee or morbus Osgood-Schlatter 2. What do they always show? They always show you CDs. And if you fix the continuum distortion, if you push, it's painful in this moment. But after, the swelling is a little bit more, but then it is fixed. Yes? The difference to the TB technique now is here I push towards the bone and in the TB I wrinkle the tissue out. Yeah. And so steroid injections are sometimes, for example, bursitis. Yes, when you have it here on the trochanter major, patients mostly show like this. I see a lot of times steroid injections can help. So I never tell my patients, no, don't take this. But ask your patients or watch your patients now after this seminar. HDP, trigger band, cylinder, steroid injections do not help. Yeah. So Dr. Tupaidos had a very, very nice analogy for the continuum distortion. It's the cornstarch water phenomenon. It's when you buy cornstarch in a shop. I tried to show it in the seminar in Tehran. And I asked Sarah, the secretary of the Tehran University for Medical Science, to buy this, and it was very hard to find in Tehran. So I brought it last time for the seminar. So if I will come back to Tehran, I will bring it. Yes, but I think you should buy it. I don't know what is the name in Farsi, but cornstarch is a non-Newtonian fluid, so it doesn't react like water. It always reacts to the external forces, and this is how I imagine the transition between ligament and bone. You see, this is the teacher here, and he is having some students, and he filled a little pool with cornstarch and water, and you see it's a fluid, but when you are fast you can walk on it because it becomes so hard.
It's all over.
So what you see in this black kid, he is actually doing shockwave. This is shockwave treatment. And this boy here in the white shirt in the front, he stood too long and he just sunk in. So this boy here in the white shirt, he's doing CD technique.
It's all over. He's going down. It's not gonna work. Oh,
And see, with the second leg now, he's doing another CD technique.
it's eating you.
Shockwave again. Yeah. Yes, it's a material which doesn't listen to the laws of Newton. I even, if you have some fun by it, I even tried it here with my children. You see my son, he's putting his finger inside, and then my daughter, she's hitting it with a hammer. Watch it. See, it's like water. And now watch my daughter. This is crazy, yes? Try it at home. You will not believe what you see. Yeah. And so if you can imagine, it's not so fluid anymore. It's too hard. We need to press on it. So the treatments looks like this. So for example, a patient shows me a CD here, tennis elbow. So the fibers of the tendon go like this into the bone. So I press like this into the bone. I will bring it if you cannot buy it. You know, the cornstarch. I will make a big cornstarch business in Tehran. Yeah. So I press in this direction. For example, if you have arthrosis in the thumb, I press always this way. I have a lot of ladies after menopause. They have here, they say it's arthritis. I press on this. Then you have the snapping finger. A lot of times they have a pain here. So I push in here. That's my technique. I always tense my fingers and I push towards the bone. Here you see some patients. She is good in bending forward, but now she has a problem when she comes up. Yes, trigger finger also, CD, yes. And trigger bend. See, one spot of pain. Somebody asked me about fibromyalgia. This is a patient with fibromyalgia. They are a lot of times very nervous, very aggressive, because I see in the beginning they have cylinder and CD. And this patient was very aggressive towards me because he told my treatment does not help. And he showed a CD. So I made a cross with a pen on his back and asked him, could you show me again the spot where you have pain?
Bei dem da hinten, ob der richtig ist, der Punkt, wo ich das. Ja, es war ein Ticken weiter innen.
And did you see how many spots he showed? And then I show the video to my patient and I tell my patient, I know you have a strong pain. That's why you're so aggressive and you have it for years. But please, it will be painful because I have to push. If this is the rib, then mostly you have to push downwards. I have to push on those spots and you just have to take these treatments. Please think about it. Will you take 2-3 treatments like this? And don't think it will be all gone with one treatment because they have like 20 spots in their back and they always show you another one. And you have to treat all of them. Yeah. And this is the technique. So I just push down with my thumb towards the bone. That's all. That's what I do. And I will show you an example of a treatment. This was a guy, this is a few weeks ago. He twisted his ankle and had some torn ligaments. Yeah. And now I'm doing the testing first. In every sprained ankle, I test how far, how high can they go up.
Oben nehmen, so zum Kopf ziehen. Weiter geht nicht. Ein bisschen sieht man schon, ne? Da hängt der rechte. Ne? Dann mal nach unten nehmen, mal strecken. Das sieht eigentlich jetzt nicht so schlecht aus. Ne? Vielleicht auch ein bisschen weniger. Tut das weh irgendwo? Wo tut's weh?
I ask him, where's the pain?
Wo denn? An welcher Stelle?
You see, he still has from the torn ligaments, he has the hematome. The torn ligaments, he played basketball, was on Thursday. This is Tuesday, so 4 days after. And he showed something on the outside. So now first, you see his lack of movement, yes? So first, I advise everybody of you, treat the CD of the anterior tibiofibular ligament. So I take my hands around his Achilles tendon and I push with the tip of my thumb upwards on his tibia. I just push up in this ligament. It's very painful for the patient. I do it like 10 seconds. It looks like this. Just push up. And then after 10 seconds, do a retest. And then you see he can move already. You see the spot there. Do you see it here? Here, there's the spot where I pushed. Yeah. And now it's similar. And then we treated also the spot on the outside. And then he could walk without crutches. Yeah. This is like magic. Because all the doctors, they give them orthesis for 4 weeks. And like I told you last time, my teacher, he's a medical doctor too, and he tells the doctors, you don't need to study 10 years to give your patient crutches, treat them. Your grandmother can tell you to use crutches, but you study 10 years, so you should be better. So I will show you another example. This is an acute sprained ankle of quite a good runner after a competition. This is on a Sunday. I was in my, our Sunday is your Friday. Yes. So it was my day off, but I was in my clinic for papers, and he called me because after a competition, he twisted his ankle. He went straight to the hospital. There's a hospital near my clinic. They did an X-ray, didn't find it. And now he comes with the crutches into my clinic. He said Kackrücken. That means, oh, this shitty crutches in German. Maybe I shouldn't translate. Okay, so here you see he got this. He had a swelling in the ligamento fibotalare, blah, 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 blah. There's no they did an X-ray. There's no fracture. There's they think it's partly rupture of the ligaments, and his treatment is orthesis for 6 weeks and ibuprofen and put the leg up and cooling and all this. I think what you all know. This is like 1 hour after it happened. He went to the hospital, and then after the hospital he came straight to me. And there you see, you can do it straight after. They didn't put a time in there, but it was like, he called me, he said, I twisted my ankle. I told him just first go for an X-ray to the hospital, so we know there's not a fracture or something. And then after this, maybe 1-2 hours after the accident, he came into my clinic. And then, of course, he needs to take off the bandages and the orthesis. There you see the orthesis here and the bandages.
Geh ruhig mal ein paar Schritte.
Yes. And now I'm provocating him a little bit because he knows about the model. This runner, he's quite a good runner in competition too. And so I have to provocate him. I ask him, why you don't walk correctly? Walk correctly. You have pain or you afraid?
Warum geht's nicht? Tut's weh oder hast du Angst? Wo merkst du den Schmerz?
And then I ask him, okay, but where's the pain? Can you see it? Isn't this interesting how he knows in an acute injury where exactly is the pain? Another one. And now you see he cannot walk. And now I'm testing how far can,
Fußspitzen nach oben. Beide, den rechten auch.
and he's a little bit afraid, so I have to provocate him again.
Wie hoch kommst du? Links geht nicht weiter. Noch weiter. Und hier? Geht nicht weiter. Geht nicht.
And now watch his ankle. Do you see the red spot here? That was the CD. So I pushed towards his tibia. I went inside, and then I pushed where the ligament goes into the bone on this spot. See, better already. Not perfect, but we needed one more push, and then it was okay. And then he made a photo of me. And then I treated his CD. I will show you a photo. Then I treated his CD, which he showed on the side. No, there's no special position for treatment. I mean, this was very painful for him already. This was very acute. So I did it in laying down because maybe, you know, he will faint or something, then he's just safe. But you could also do it in sitting. And see, now he can walk again. He said, I will run home. That's like goodbye in German. Yes. So you see, you just need to follow the pathway of the ligaments. So he showed us the anterior talofibular ligament also and the calcaneofibular ligament. But these ligaments are just for orientation. So you know you have to push downwards, not perpendicular to the skin, but downwards. So you have to follow the pathway of the ligament. You see here, that's an original photo for 10 seconds. Yes, 10 seconds, maybe 15 seconds. You don't need to push very, very long. Yeah, 10 seconds is okay. Yeah. And as you see here, that's from the original book from Dr. Tupaldos. You need a proper direction and an adequate force. And this is one of my students. She cut the ligaments of rabbits, and she did her dissertation as a medical doctor with the ligaments in rabbits. And this is after surgery. And watch this. The upper picture is immobilized. The below picture is mobilized. So what do you think if the patient will have an orthesis and crutches? Do you think it will look like immobilized or mobilized? It will look like mobilized. And if you have a sports guy, the ligaments to heal, they need movement. I think the fibroblasts, they need movement and they will heal much better. And I always tell my patients, this guy, for example, he asked me, Torsten, can I do running again? And I said, like, you know, it's a difficult question. I mean, I don't want you to tear your ligaments again because he didn't have pain after my treatment. But I asked him, what do you feel? What does your instinct say? And he told me, you know, it feels like something is working in there. And I think it's not good to run. I told him, okay, then just go walking, you know. He didn't need to go to work. So then he sent me videos how he was walking in the woods. He wore some basketball shoes, you know, then he felt better and he mobilized and he healed much faster. And this is the reason why the fascial distortion model is used so much in sports today. So this was a little part of what we would do in a live seminar. So in the seminars that I gave in Tehran so far, we did the module 1 and 2. The module 1 is a shoulder, knee, ankle. The module 2 is a refresher of the module 1 and the whole spine and the pelvis and the hip. And your module 3, what we didn't do so far in Iran, is the refresher of module 2 and upper extremity, lower extremity, and head and craniomandibular joint. And then we mostly have a basic certificate where you get 25 questions, you get a theoretical and practical exam, and then if you pass it, you get a basic exam certificate. Yeah, this is the official way how to go. So if all this Corona stuff will end someday, then I will think I would be the first to come to Iran and meet hopefully a lot of you guys and give you and share more of my knowledge that I collected so far. Yeah, it's very, very important for this. I hope to. It's very important that you enjoy really the new perspective with your patients, and that you see for yourself how much we live in times where we rely on objective findings like symmetry, muscle hardening, X-ray MRIs, and we forget the people. That's what we sadly forgot in medicine. And I just want to give this back. Yeah. Listen to your patients, watch the body language. And if you have some problems, yeah, if you have some problems, just contact me in WhatsApp, contact me in Instagram or via email as you want. And I think everybody will see that I'm trying really my best to answer you very, very fast and to help you and to keep in contact. And even if you have some success in your patients, I would love it if you share it with me. Yeah. And if you have any more questions, I will talk to the Iranian Physiotherapist Association, and maybe we can do some more seminars, and I can explain some more distortions. We missed the tectonic fixation, we missed the folding distortion, but it was just 4 hours, so I tried to give you something for the clinic that you can really use in your clinic, and I hope you will enjoy your success with your patient, and you will enjoy the FDM as much as I do with your patients. Okay, I want to say a big, big thank you to all of you. Thank you for all your questions. And I hope everybody or a lot of you will stay in contact with me. And I like to thank again the Iranian Physiotherapist Association for inviting me and making this possible. Thank you very, very much. And Khasta Nabashid.
Hello, everyone. It's a great experience for us to spend 4 hours with Dr. Fisher and friends and colleagues from different parts of Iran. It was like a great journey. Dr. Fisher, I admire your efforts in learning Persian. As you know, I'm learning French and I can find how it's difficult to learn a new language. It's a sign of your kindness to Iranians. Merci à vous pour votre coopération avec nous. Ici, nous avons beaucoup de professeurs de la langue persane. ما یه عالمه معلم فارسی اینجا داریم سر کلاس. à la fin, thank you all. And Dr. Fisher, we hope see you soon in Iran.
Okay, for me it's the same. Okay, have everybody a good night and Khasta Nabashid.
Have a good night.